Well, dear colleagues, I welcome you to the first webinar of the vascular section of the ENS in this year. I am quite happy to welcome Simone Fistula from the University of Catania, who will give his talk. While last year we had a lot of talks about surgical techniques, surgical indications. Now we are looking on the field of vascular diseases, more from the endovascular perspective. And I think for this talk, Simone is the perfect choice for us. He's also the ENS vascular section member, so he's also well engaged in the whole ENS community. And I'm quite happy that we're doing the webinar together. He will give his talk. It's around 45 minutes of presentation, which is followed by a discussion. I would be pleased if all the questions from the participants are put into the questions section. I will go through it after the talk of Simone, and then we can address all these issues which are interesting for you. So Simone, I'm very pleased to welcome you again, and I'm happy that you're here. And yeah, I'm looking forward to your presentation. Please, Simone.
Thank you, Veit. Thank you, everyone. Thank you to join us. I will talk about new devices in endovascular neurosurgery, and we will divide this talk the new devices and the characteristics of them. And the second part, I will talk to you about one clinical case that is very interesting. I have no disclosure. And we start to talk that normally we fighting with open vascular neurosurgeon when we have to when we decide to treat a patient. But I think that this is not correct. We should be at the same team, and we should choose the right treatment for the patient. I think that if you don't know the past, you cannot understand the present, and you cannot plan for the future. And I think that we should start to talk about the past, just a couple of slides. And we should always think outside the box. I mean, the pioneers of endovascular neurosurgery are Egas Monitz, that in 1927 invented the cerebral angiography, helped by a Portuguese neurosurgeon. Fedor Serbinenko, that in 1974 invented the detachable balloons, the first endovascular devices of the history. And Guido Guglielmi, that in 1991 has invented the GDC, the Guglielmi detachable coils. If there were a Nobel Prize for clinical experimentation and research, surely Dr. Serbinenko and Dr. Guglielmi would be one of the neurosurgeons considered for such an honor. Egas Monitz was a neurologist, Fedor Serbinenko was a neurosurgeon, and Guido Guglielmi is a neurosurgeon. As I told you before, Serbinenko has invented this detachable balloon, and it was an incredible discovery to use this detachable balloon to treat, from an endovascular point of view, the cerebral aneurysms. To date, more than 3,000 patients have been evaluated or treated by Serbinenko using balloon catheter techniques. Guido Guglielmi in 1991 made a big step forward he invented the detachable coils, and in this very important private drawing that Guido Guglielmi has shared, here you can see the name of the engineer, and this is the fax number where he sent these technical characteristics to create the very new coils and different shapes, like in the right side, the butterfly coils. So there started the history of Guglielmi detachable coils, and we have a couple of milestones regarding these devices. In particular, this one is one of the top 10 most cited articles in neurosurgical journals. To date, it received 2,157 citations. And this is very interesting article that talk about the history of his discovery. And what about the present? In the present, we have hemorrhagic stroke devices and ischemic stroke devices. We will talk in the first part about the hemorrhagic stroke devices. We have coils, flow diverter stent, a balloon for the remodeling, glue, non-adhesive liquid for AVMs, low profile stent, and detachable balloons. But I think that we have talked about two kinds of approach. We have an intrasaccular approach that is provided by, for example, the Coils that started in 1991, and the extrasaccular approach that started in 2008 with the clinical use of the flow diverter stents. About the intrasaccular approach, we have the cure by mechanical feeling. We have coils and coils plus stent, and different kind of this stent. And cure by hemodynamic change and biological process, because as we will see in the next slides, there is also a biological process, like in the web and in the couture device. And in the extrasaccular approach, we have the cure by hemodynamic changes and biological process, like in the flow diversion stents. In this paper that we have published in 2020, we have compared the surgical clip, the surgical treatment with the new endovascular techniques, because still there was always a comparison between clips and coils, and that is not good for the present, because we have a lot of new devices, and we aimed to compare the result of these new devices. Another key point that I think it's very important, and probably we later discuss on it, is the complete occlusion rate, and immediately or at the follow-up. Because I think that a great mistake is to compare complete occlusion among clip and coiling, but we have to evaluate the risk of rebleeding. Okay, we are talking now about the extrasaccular approach. We have a lot of devices like the flow diverter stent that started the clinical use in 2008. The very first one were Pipeline and Silk, and then we had Fred, the Revo stent, Surpass, P64, P48, and the Tarbridge. Everybody knows that how this flow diverter works. They work to reduce the flow inside the sac and to redirect the flow inside the stent. And this can help the thrombosis of the sac and the occlusion of the sac itself. But it's very important to talk about the re-endotheliation of the stent itself, because this is the reason that can explain why there is a complete cure of the aneurysm at the follow-up. The mesh are completely different compared to the no flow diverter stent. This is the mesh of a flow diverter stent, and look here, those are the mesh of a no flow diverter stent. So they are very, very complex and very, very numerous. And when we put the stent in the vessel, we can change the geometry of the square of the about the fenestration of the stent itself. So we can play to push or to retrieve the stent to improve the flow diversion of the stent itself. As I told you before, the very first one stents were pipeline and silk. Then we had Fred. P64 was the first flow diverter stent that was detachable, and it was a very impressive innovation. And then we had the Surpass Evolve that at the beginning was very, very stiff and was quite hard to deliver. In the last couple of years, we had many studies about the coating of these stents. In particular, for example, from Phenox, they have created this HPC coating that mimics the glycocalyx that are the natural lining of the endothelium, that indicating an intact vessel wall, and this can reduce dramatically the risk of instant thrombosis. And a very similar coating is on the pipeline, in the pipeline shield, and the goal of this coating is to use only one antiplatelet therapy, antiplatelet drug, and to use it on for example, on the acute stage, for example, for rupture aneurysms. Every kind of stent has a different kind of characteristics. For example, the pipeline has a 48 number of braids. Surpass is one of the most among the flow diverter stent of P64 has a 64 number of braids, and Fred is a different one because he has it has a low porosity inner mesh, and outside there is a higher porosity mesh just at the level of the neck of the aneurysms. In the market, we have a lot of no flow diverter stents with different shapes, but we can summarize in two big groups: the laser cut stent and the braided stent. In the laser cut stent involves removing material from a tube, creating openings surrounded by struts that deform from rarely compressed configuration to the expanded configuration. Braided stent comprise multiple wires interwoven into a cylindrical shape. Let me show you how is performed. Is create a laser cut stent. They start from a tube and then is shaped like the final shape of the stent. And the braided stents are made by many wires along one tube. And here you can see how it is done. For example, we have the laser cut open cells like Neuroform, Wingspan, and Acclino. And we have also braided stents closed cells like Enterprise, Solitaire, and Elvis Jr. And with this no flow diverter stent, we can use it in the SAC technique, so stent assisted coiling, like in that case, with a coiling through. So we put in the stent, and then we navigate through it with a microcatheter, or with in the jailing fashion. So we put first the microcatheter inside the aneurysm sac, and then we deploy the stent into the vessel. We have a lot of shapes in how we can deploy the stent in the X fashion, for example, for anterior communicating artery. So they are two stents like an X. So from the right A1 to the left A2, and from the left A1 to the left A2. In the Y technique, so we put, for example, in the top basilar aneurysms and in T shape. We have another one device that is called Comaneci, that is a retrievable stent, and it's very similar to a balloon. But the big difference is that when you inflate a balloon, you experience the occlusion of the flow. But if you use the Comaneci stent, you can use this remodeling device, but the flow is still open. And here you can see how this device can help you to coil an aneurysm. And here you can say the stent. Here is the aneurysm neck, and here are the coils. Another device is the so-called Piconus, and this is the very first version. This is the second one, and it's very simple to the idea, because you can left the first part of the stent inside the sac, and you can navigate inside the stent to put the coils here. And it was created to avoid the risk of the Y stenting that is here. It's just an overlapping of the struts that can create and can increase the risk of in-stent thrombosis. We have also another device. It is called a pulse rider, and it works inside the sac, and can help you to create a neck of the aneurysm. Let me show you how. This is the stent assisted coiling, the Y shape technique, and this is the pulse rider technique. So you have to release the device, but you have to release the flare not outside the sac, but inside the sac. You have to play till you have put the flare inside the sac to create a new neck, and then you can use the coil to close it. Another device is called Eclipse. is still in a developing phase. It's like a leaf that create a neck for an aneurysm. Here you can say how it works. You have to release the device in a side branch. Then when it's totally released, you have to push the microcatheter to release the device at the level of the neck, and then you can go through the device and put some coils. Let me show you how is different extrasaccular approach with the intrasaccular approach. We have talked about the coils. We have a lot of different kind of coils and shapes. The very first one was only helical coils. Then we had the 3D coils, very different shapes. And this was the very first intrasaccular device. In the last years, we have a new version of the intrasaccular balloons, like the Sebenenko idea, but very much more softer. And this is the web. The web, it's a very soft cage that goes inside the sac, like in these two drawings. And how it works? Because it works is you have to, here you see the aneurysm sac. Here you see how the web is deployed. So it's deployed totally inside the sac. And this is the just after control. So in the majority of the cases, you have the occlusion of the aneurysm. Sorry. And this is a 6 months follow-up, where here you can see the shape of the device and the aneurysm is gone. It was reported also the use of this device in ruptured aneurysms. For example, in that case, you see subarachnoid hemorrhage. It was found this aneurysm, and then it was treated. The neck of this aneurysm was treated with the web, and this is the final control. Another device that is just out on the market is this contour device, and it's 2 per 72 nitinol wires. It's like a basket, and its role is to cover the neck of the aneurysm, and this is one clinical case done with this device. Here you can see this anterior communicative artery aneurysm that was treated with this device. Here you can say you can see the shape of the aneurysm, and here the final result compared to the beginning of the treatment. There are so many clinical trials and clinical series that have reported the results with these devices. And for example, flow diverters has experienced of 1 year occlusion that is very high rate for an endovascular device. We are at the beginning of the experience with contour, but it was reported 14% of morbidity. So it should be much more investigate this kind of device and its complication. But let's talk about the comparison of extravascular, extrasaccular and intrasaccular devices compared with aneurysm location. For example, for ophthalmic aneurysms, extrasaccular has a pros on that the aneurysm orientation is not a limitation. And the cons are that the risk of embolic complication of the covered ophthalmic artery. Intrasaccular might avoid embolic complication of the ophthalmic artery covered by flow diverters, but aneurysm orientation is a limitation because normally this kind of aneurysms has often have a neck very wide. For PCOM aneurysms, we have that extrasaccular devices has no limitation regarding the aneurysm orientation compared to intrasaccular devices that might avoid embolic complication of PCOM covered by flow diverters. And PCOM aneurysms dimension and type are not a limitation. And if we compare the devices in the treatment of MCA and ICA terminus or in the basilar apex, for example, extrasaccular devices has a higher occlusion rate, and they can create geometrical changes that can be induced by the flow diverter. And this can reduce dramatically the recurrence rate. Intrasaccular devices might avoid embolic complication due to the covered branches, but have lower occlusion rate. And finally, if we compare the devices for ACOM aneurysm, we can see that extrasaccular and intrasaccular have a good efficacy and allow low ischemic risk for both groups. But let me talk you about this balloon that is called Copernic, and that can allow us to treat very complex vascular disease. For example, dural fistula. We have started to treat this lesion with this venous balloon that can allow us to left the venous the sinus open, but to treat the sinus, the vein foot. We know that we have a different kind of dural fistulas, and the much more risky are the type 2B, type 3, and type 4, for example. Let me show you a clinical case. This is a case of a male, 74 years old. 6 months before, for appearance of a progressive dementia, the patient was referred to an Alzheimer's specialist. But due to the onset of confusion and drowsiness, the patient was taken to emergency department where he underwent a brain CT and a brain MR. And the brain MR show this picture that is clearly define a dural fistula. And here you can say a very rare phenomenon that it's those are veins, hypertrophic veins, because this patient experienced hypertension venous system. This is the the run, and you can see how the vein system was so stressed, because here you can see all these veins that previously I showed you in MRI. There were a lot of feeders, for example, from the carotid, the venasconic and cincinnati artery. This is ischemic pharyngeal artery, and here you can see the reflux into the straight sinus. Again, from the lateral point of view, and you can see okay, the label vein, yes. Okay, here from a frontal point of view, you can see the middle meningeal artery. From the lateral point of view, the medial meningeal artery, and all these feeders goes to the transverse sinus. But this patient had also a contralateral feeders from the ischemic pharyngeal artery that cross from the right to the left side, occipital arteries feeders. And here you can see always the label vein and the middle meningeal artery feeders. So it was very complex case, and how we can approach it by endovascular treatment. Here, this is a drawing that can summarize the problem. So in that case, here you can see the 3D. In that case, we have treated this patient in two steps. One step from the left side with two approach, from the arterial approach and the vein approach with the venous remodeling. So we use this middle meningeal artery feeder. We put this microcatheter, and here in the arterial side, and here in the venous side, we put the balloon. Here, this is the balloon, and here you can see the tip of a microcatheter. So we use the pressure cooker technique. So we have put some coils. Before we have put here the microcatheter, those are the coils, and then we have put glue to jail the microcatheter and to avoid the reflux. Here the run, where you can see this is the glue. Okay, and from that we have started to inject onyx after we have inflated the balloon in the transverse sinus. Here you can see the cast, and this is the remaining from the left side. This is a vaso CT control after the first treatment, and here you can see the hyperdensity of the onyx cast. This is the CT post. Here you can see the first onyx cast. Then after 1 week, we have treated this patient from the from the right side in the same fashion. So we have put the first microcatheter on the right, the second one. We have put the balloon. Here you can see it. And then we start to inject from these two microcatheters. And here you can see the evolution of the cast, and this is the final result from AP view and from a lateral view. This is the final run from the right side. And here, this is the final run from the right side. And you can see that the patient now has no more venous hypertension. And very interesting is that the transverse sinus is still patent. That's very important. At 3 months follow-up, the patient experienced a complete remission. Okay, let's talk about ischemic stroke devices. We have seen that from the 2000 years, from 2014, 15, 16, and till 2020, we had a great evolution of endovascular devices for the stroke treatment. Here you can see how the stent retriever technique works. Here you can see the clot. The clot occlude the MCA, for example, in this example. So you have to bypass the clot with a microcatheter, and then you have to release the stent across the clot. You have to wait a couple of seconds to allow the stent strut to go inside the clot, and then you can retrieve the stent and the clot. And you can see just after the reopening of the vessel and the flow. We have a lot of stent retriever. The first one was the Solitaire, but we have Revive, Trivo, and so on. After the stent retriever technique, it was created this ADAPT technique that is an aspiration technique, and it works. It is very simple because you have to push the microcatheter very close to the clot. Then you start to aspire with the aspiration tube with a pump, and here you can see how it works because you have to wait, and in some cases you can remove completely the clot. Otherwise, you can remove the microcatheter, like in this case. You can engage the clot and you can retrieve the microcatheter and the clot together. These are a couple of examples that show how it was evolution of these devices from 2004 till 2012 and with 13 with the stent and ADAPT technique. Finally, we will talk and we will think about the near future. One more thing, this probably will be the new neurosurgery OR. Nowadays, there are many centers in Europe and in the USA or in Japan that where this operating room is the present. An operating room where are the microscope, the neuronavigation system, and the angiography system. We have this hybrid suite where we can use this hybrid suite for a complex vascular lesion. For example, this was a very complex AVM case that was treated by surgery, but it was very useful to see. This is the pre-treatment angiogram, and these are the intraoperative control, and this was very effective. I think that vascular neurosurgery will play always an important role, but as neurosurgeons, we have to use the microcatheter as we do with the scalpel, and as Americans and Japanese neurosurgeons already do. Thank you so much.
Yes, thank you, Simona, for this very nice overview on the possibilities we have now for treating complex vascular diseases. So I start with a few questions of mine, so to warm up the participants, and please put your questions into the Q&A section, and then we can, or Simone can answer them. I would, because I'm more on the surgical side, let's say, and for me, when I'm always being confronted with the new devices, I always ask myself if we have enough scientific proof that the new devices, let's say the web or the contour, are truly better than surgery. I think we all know the ICEP data, and we are well aware that we possibly should not operate a basilar tip aneurysm. But for the new devices, I think we have not, let's say, rock solid scientific data that says that the new devices are better or at least as good as surgery, especially in aneurysms in which the ICEP trial more favored surgery, such as MCA aneurysms. What's your opinion about this?
Yeah, I agree with you, and for that, I think that endovascular treatment should be done by neurosurgeon too, because if you treat patient, if you treat endovascular, if you treat patient by endovascular treatment, you can, and you are a neurosurgeon, you can see both the half of the apple. I think that this is very important, and because as I said, vascular neurosurgery will play always an important role, and we never forget that we have never forget that there is an option that is the clip. So the clip is not now the devil. We have learned if the new devices are good enough as clip. I mean, for we have seen that these new endosacral devices can help us to treat some kind of these aneurysms, but clip remains an excellent tool to treat this lesion as well. I totally agree with you that we have enough scientific proofs that these new devices are enough safe and efficient compared, for example, with the clip or with coils. But you know, now we have. When I started my endovascular course in the market, there were just a couple of devices. Now, in the last 5 years, we have a lot of new devices. So we have a lot of pressure from the companies to try this every new devices that is out on the market. But I think it's very important to use the brain, use your experience, and wait for clinical data to use new devices.
Okay, now I see 2 questions. For me, the most interesting thing is always mostly the aneurysms, but they're belonging to the Wayne of Galen malformation. So there's a question. I can't wait to see new era about Wayne of Galen new management plan. What let's say perspectives do you see, Simone, in the management of vein of Galen malformations? Do you have some comments for this?
Vein of Galen malformation are a very rare disease, and normally this kind of disease, I mean, in Italy, are treated in a couple of centers. And I think that it's very important that rare disease have to be treated in just one or two centers, because they can reach the top level clinical assistance. I think that a couple of words is not enough to discuss about this vascular malformation. If you want, we can organize another web seminar, and we will talk about that.
Okay,
because it's very complex.
It's complex. It's not so easy, and as you said, it's truly rare. It's truly rare.
Yeah.
The question about the vein of Galen malformation was linked to another question. The question is coming from Khaled. I think he's based in Africa, and he asked us when these new devices are supposed to be available in Africa. What do you think? How the industry are pushing the development and the distribution all over the world, or more in Europe or in US and in Japan? Well, what's your assumption?
Yeah, I think that the greatest market in the world are North and South America and Europe, and on the second step, Japan and China. In Africa, I think the big problem that all these companies want to earn from these devices. So Africa, it's a big continent, and I think probably just South Africa can pay for these very expensive devices. I don't know if this company have planned to expand their market in Africa.
Which is a pity, because if we have good devices, so it's hard to say that it only can be used in certain parts of the world. There's a question, I think it's from Greece. Nikos is asking about your case of dural AV fistula. He asks if combining arterial and venous approaches might increase the risk of ischemic events.
But ischemic events, why? Because I think that it can prevent ischemic events. I think that venous remodeling can allow you to close the vein foots, but maintain the sinus open. So I think that it could prevent ischemic events.
Okay, I have a question, because now I don't see any further questions in the Q&A section. I have a question why the term of the adequate occlusion rate was introduced into the endovascular literature for the intracerebral web and contour device. Because it seems a bit for me not to admit that at least the occlusion rate on the angiogram is not as good as with coils or with clips. Why do you think this adequate occlusion rate was introduced as a, let's say, new parameter?
Yeah, this is very good point, Veit, because we are when we are using a clip, the occlusion rate it's around 95-98%. With these new endosacral devices, for example, for web, the occlusion it's around 80% at 6 months follow-up. But I think that we should move a step forward, because I think it's a mistake to see only the occlusion rate. We have to see or complete occlusion rate, because in the majority of the cases, this device can create a partial or not complete occlusion, but the rebleeding risk is very, very low, as for example, the BART study has demonstrated. So I think that we should move not to see the occlusion rate or subocclusion rate, but we have to talk in terms of rebleeding risk after the treatment. But this is my opinion.
It's a bit of a paradigm shift, because we need to have parameters how to define the benefit of treatment, especially if you're doing comparative studies. Do you truly think that we have enough data, especially long-term data, to say that, let's say, a web device is as good as let's say a clip? Because if we are looking into the re-rupture rate, it's on the short run, it seems to be similar, but we don't know if it's truly durable, if you're durable results, and if on the long run, possibly, let's say, clipping of an MCA aneurysm would be better.
Yeah, unfortunately, we don't have till now a very long study for these kind of devices. So we have to wait, and particularly it's very difficult to design a prospective study, a long prospective study about these devices. I think that we have to wait and to see in the next future and analyze retrospectively the data from the first cases that were treated by the web, for example, because the web is the first intrasacral device.
Why do you think that doing a randomized trial again using web against clipping would be difficult to set up?
I think that it's very difficult to project a prospective multicenter study for example for 3 or 5 years that it's midterm follow-up. I hope that it was done, but I think it's very difficult to collect so many centers to reach enough big data to have a statistical importance.
So I don't see more questions in the Q&A section. So at the end of this webinar, I would like to ask you about, let's say, the hybrid neurosurgeon. You stressed that only a trained neurosurgeon could decide how to treat best a vascular case. You know that at least in Germany, the situation is different. So we have neuroradiologists, which are radiologists trained to be neuroradiologists, and we have the neurosurgeons. There's a lot of discussion. The situation is different in other countries in Europe and in the US. But at the very end, if you're a hybrid neurosurgeon, do you think that you're always your performance is always equal if you're doing both, or if at the very end you're going more in one direction or the other direction?
Actually, wait, I do only endovascular, but I think that in my experience, I have decided to do only endovascular and not both, because I think that if you want to reach the top level, you have to choose what kind of branch you have to do. We have a lot of great surgeons that do both endovascular and open surgery, for example, Giuseppe Lanzino. But I think that we should use the Barrow Institute model. I mean, Michael Lawton do only open vascular surgery, but he done a fellowship in endovascular treatment. And Felipe Albuquerque is an endovascular neurosurgeon, but he had an open vascular background. This is my experience, and this is what I think. I hope that the new European young neurosurgeons wants to try to do endovascular treatment, because I think that it's important, like Americans neurosurgeons do or Japanese do. It's very important not to fight against the interventional neuroradiologists, but to work with them to offer the best treatment for the patient.
Very good final words. So there are 3 comments in the chat. There's one from Dr. Walid Al-Salavi. He was the guy who asked the question about the devices available in Africa. He's from Sudan, and I think he would like to contact you. He asked if it's possible.
Yeah, sure.
Yes.
Absolutely. You're welcome. I show you my email.
Feel free to contact Simona. He will be happy to answer all the questions, the further questions.
Absolutely. If you have any comments, or if you want to share your cases, I always available to discuss with you.
Great. And there are 2 comments that said that it was a very great presentation.
Thank you.
Yes, it was a very great presentation. I loved it. I was very pleased to hear it. I thank you, Simona, for your talk. I thank all the participants to be with us at this webinar. And I would be happy to welcome you to the next webinar of the vascular section. I think it will be roughly in one month. So thank you for being with us. Thank you. Goodbye.
Thank you. Thank you, Vai.